about pulmonary proliferative disorders. We will see the spectrum of lymphoproliferative disorders, benign and malignant, and also biopsy considerations. The spectrum is from benign processes to malignant. In the benign process, there is polyclonal proliferation of lymphoid cells in the lung, and these processes are uncommon. We can see nodular lymphoid hyperplasia, follicular bronchiolitis, and lymphoid interstitial pneumonitis. The malignant process are monoclonal proliferation of lymphoid cells, and in this we divide it to primary pulmonary lymphoma with involvement of the lung only, and secondary pulmonary lymphoma in systemic lymphoma. Bronchial mucosa-associated lymphoid tissue, or MALT, is a submucosal bronchial lymphoid aggregates which is absent in healthy, but can develop under chronic antigenic stimulation. For example, in patients in smokers, in immunologic disease, occupational disease, and chronic infection. In the benign lymphoid lesions, we see development of MALT tissue. The nodular lymphoid hyperplasia is rare. Patients are asymptomatic, and it's usually incidental finding on imaging. And we can see a nodule, average diameter of 2 centimeters with irregular margins, probably reflecting local lymphangitic spread. Follicular bronchiolitis and in lymphoid interstitial pneumonia, these patients are usually symptomatic with cough, dyspnea, and fever. Follicular bronchiolitis, we see MALT hyperplasia, which is localized to the submucosal bronchioles, and the LIP, lymphoid interstitial pneumonia, is the same process, but it's more extensive, involving not just the bronchioles, but also the lymphoid cells enter the lymphatic tissue in the interlobular receptor and subpleural spaces. Follicular bronchiolitis, usually we see it as a secondary findings in patients with chronic bronchitis and bronchiectasis. We see it in pathology. And the symptoms of these patients are related to the primary disease, not the follicular bronchiolitis. But follicular bronchiolitis also can be primary, especially in patients with collagen vascular diseases or in patients with immune deficiency syndrome. And in these patients can have symptoms, as I spoke before. Usually, patients are females in 40 to 60 years, and we cannot differentiate follicular bronchiolitis from chronic infection. We will see an example later on. LIP, also, patients are symptomatic, and also we can see it in two subgroups, patients in females, mostly females in 40 to 60 years with collagen vascular diseases, and also in children with HIV. Follicular bronchiolitis, what we see is twin bud patterns of centrilobular nodules, and also thickening of the bronchi and bronchiectasis. In these patients, we cannot differentiate from chronic infection, for example, patients with atypical mycobacteria, and only when we don't see an organism, then we say it's follicular bronchiolitis. Lymphoid interstitial pneumonia, as we saw before, the CT pattern is we have many CT appearances. We can see if the disease is localized to the bronchioles, so we can see centrilobular nodules, or even lung cyst, as we saw in the former lecture. This is a patient with Sjogren Syndrome and pulmonary cyst with LIP. In these patients with collagen vascular diseases, sometimes the only finding for LIP is lung cyst. You don't have to see any other findings. In contrast, patients with HIV, usually we see centrilobular nodules and patchy ground-glass opacities, much more extensive disease than patients with collagen vascular diseases. Pulmonary lymphoma. We have primary pulmonary lymphoma, which is confined to the lungs only, and it is a rare disease, as opposed to secondary pulmonary lymphoma, which is involvement of the lungs in a patient with systemic lymphoma. It's much more common. Primary pulmonary lymphoma is monoclonal lymphoid proliferation. It is in the lung parenchyma or bronchi, and without extrapulmonary involvement at diagnosis or during subsequent 3 months. It is a rare disorder. It's 0.3% of primary pulmonary malignancies and only 1% of non-Hodgkin's lymphoma. Most of the primary pulmonary lymphoma are B-cell lymphoma, and 70% of all the primary pulmonary lymphoma are MALT lymphoma, mucosal associated lymphoid tissue lymphoma. The 20% are diffuse large B-cell lymphoma, and all the other lymphoma, we can have other B-cell lymphoma and also T-cell lymphoma, are rare. MALT lymphoma. MALT lymphoma is an extranodal lymphoma. It doesn't have to be in the lungs. The main location is in the stomach, where it is associated with Helicobacter pylori gastritis. It can happen in other sites, in the thyroid gland, salivary gland, lacrimal gland, bronchus, and breast. It is associated with chronic inflammation and formation of lymphoid tissue. Pulmonary MALT lymphoma arises from bronchial MALT, usually in the 5th to 6th decades, and also is associated with autoimmune disease, as all the other lymphoid processes in the lungs. Usually patients are asymptomatic. The CT findings, the main feature are bilateral and multiple pulmonary nodules, which are in peribronchovascular distribution. We can also see in this patient bronchiectasis and bronchial wall thickening. This is an example of multiple bilateral pulmonary nodules with irregular borders. In this patient, we have a pulmonary mass, a single mass in a smoker. This patient was referred for lung biopsy, and they thought it was a lung cancer. And biopsy, it was found to be MALT lymphoma. We can see in this patient also small other pulmonary nodules, which are in peribronchovascular location. In many patients with primary MALT lymphoma, we can see also bronchiectasis, for example, in this patient, and also small centrilobular train bud nodules. And this patient who had chronic sinusitis and bronchiectasis known for several years. He was treated for repeated pneumonia, and he developed a mass, a consolidative mass in the left lower lobe that was unchanged for about 6 months, even after antibiotic treatment. You can see it also has a ground glass nodule in the same lobe. He referred for lung biopsy because of the unresolution of this mass, and on lung biopsy it was found to have a MALT lymphoma. Another patient, a young patient, in about 37-year-old woman with a non-resolving lesion here in the right lower lobe. We can see the lesion is in a peribronchovascular location, and also more distally we can see ground glass opacities. The patient also has a delicate bronchiectasis in the middle lobe and centrilobular nodules on the other side. FDG uptake in the lesions in patients with primary MALT lymphoma depends on the size of the lesion and also the activity of the cells. And we can see in the two patients that we saw before, FDG uptake in the lesions. Primary pulmonary lymphoma, MALT lymphoma, is an indolent disease with 5-year survival above 80%. They may develop a relapse in the lungs or other MALT sites, or undergo a transformation to more aggressive lymphoma. There is no consensus about the treatment. Patients can be followed up only, surgery consideration if it's a single lesion, or even treated with chemotherapy. The patient with the pulmonary mass that we saw before, the decision was not to treat him. It was asymptomatic, and this is an 8-month follow-up examination with we can see basically no change of the lesion. The other patient with MALT lymphoma that we saw before, so the decision for him also follow-up only, and this is a 1-year interval of examination, and we see the left lower lobe mass here basically unchanged, but the ground glass nodule is now solid. So we saw a primary pulmonary MALT lymphoma, which is about 70% of all the primary lymphoma. The other common type is diffuse large B-cell lymphoma. When it's only in the lungs, it's primary lymphoma. It's about 20% of all primary pulmonary lymphoma, and it's probably also underestimated because of the early spread to other organs. It is also associated with immunodeficiency. For example, we can see it in transplant patients and HIV patients. Usually, patients are symptomatic. They can have B symptoms or cough and dyspnea, as opposed to the former patients with MALT lymphoma. So, because it's more aggressive lymphoma, the lesions or the masses can cavitate or undergo necrosis, which we didn't see before in the MALT lymphoma. This is an 11-year-old child with ataxia telangiectasia. We can see bronchiectasis in the left lung, and there is a single lesion, a single mass in the right lung, which also did not change after extensive antibiotic treatment. The patient had a CT-guided biopsy with the diagnosis of diffuse large B-cell lymphoma, which was found in the lungs only. Another patient with pulmonary nodules, bilateral pulmonary nodules and masses, we can see also underwent CT-guided biopsy with the diagnosis of pulmonary diffuse large B-cell lymphoma. There is another rare type, which I didn't mention before, called lymphoid granulomatosis. It mimics Wegener granulomatosis, both clinically and radiologically. It's a very rare disease. It's angiocentric and angiodestructive. And in imaging, we can see bilateral pulmonary nodules, mainly with a lower lobe predominance. The nodules can be migratory and with ill-defined borders because of the hemorrhage. Okay, so secondary pulmonary lymphoma is much more common than primary pulmonary lymphoma. The lungs are involved through hematogenous dissemination from distant site or contiguous invasion from hilar or mediastinal site involved by lymphoma. 80 to 90% of patients with secondary pulmonary lymphoma are non-Hodgkin's lymphoma, and although only 24% of non-Hodgkin's lymphoma have lung involvement, as compared to Hodgkin disease, where we see more patients have pulmonary lymphoma, because Hodgkin disease is a rare disease, we see it much more often in patients with non-Hodgkin's lymphoma. In non-Hodgkin lymphoma, we don't have to see mediastinal or hilar involvement of lymphoma, but in contrast, in patients with Hodgkin disease, most of them have hilar or mediastinal lymph node enlargement, and the disease can be continuous with the lymph node enlargement. So we have many CT findings in secondary pulmonary lymphoma. These findings are non-specific. We can have a single nodule. For example, this patient with low-grade lymphoma, this is a relapse of his lymphoma with a single nodule in the lung. CT CT-guided biopsy showed a low-grade lymphoma. Another patient with we see this patient with enlarged lymph node in the axilla and also enlarged lymph nodes in the portocaval area. We can see bilateral consolidative mass in the lungs. This is a lesion in the left upper lobe. We also see in this patient other nodules and masses, mainly in lower lobe with a lower lobe predominance. CT-guided biopsy, low-grade lymphoma. Another patient with a skin lymphoma. This patient had pulmonary CT findings in the lungs, which was seen incidentally because the patient underwent a chest radiograph for other reason, and then they saw findings. She had a CT, and these findings were seen and followed up for 1 year with no change. Then the patient was discovered to have skin lymphoma, and they wanted to see if the lesions in the lungs are also due to her lymphoma. So what we see in this patient are mainly peripheral and peripheral elongated nodules. You can see this here in the paracardiac region, also another one here, and this one in the middle lobe. The patient had a PET CT with we see FDG avidity in the lesion in the lingula. This is the lymphoma in the skin, in the hand. And the CT-guided biopsy showed a low-grade B-cell lymphoma. Another patient with MALT lymphoma, this is a relapse. She was treated for lymphoma 16 years ago. Then she was found to have lung nodules. They were followed for 10 years. So this is a CT from 2004, and we can see lung nodules. In 2014, the lung nodules, few of them are even decreased in size. For example, this nodule and this nodule, as opposed to this one. But also this patient developed new nodules bilaterally. And the patient had a CT-guided biopsy for this nodule, which was found to have low-grade lymphoma. The decision was not to treat this patient. We can see a slight FDG activity of this small nodule. So what we see in patients with lymphoma is a pattern which is repeating. The nodules are mostly peripheral and also with a lower lobe predominance. This is another patient with low-grade lymphoma and secondary involving the lungs. And another patient, we see bilateral pulmonary nodules, mainly in peripheral location. Another patient now with a more aggressive lymphoma, diffuse large B-cell lymphoma with lung masses. We see the FDG activity in one of the masses. This is another patient with diffuse large B-cell lymphoma. This patient had MALT lymphoma in the orbit, and now she developed many lung nodules. We see also the peripheral and also more lower lobe predominance. CT-guided biopsy from this nodule, diffuse large B-cell lymphoma. Another patient, we see also the peripheral distribution of the nodules. And the uptake on PET. And again, another patient with diffuse large B-cell lymphoma, we see lower lobes predominance pulmonary nodules. Diffuse large B-cell lymphoma. This patient also had a retroperitoneal mass and mass in the mesentery. Another appearance in the lung is a mass which is continuous with the lymph node. A large lymph node can be mediastinal or hilar lymph node. This patient had a right hilar lymph node, and we see a developing mass in the right lung, which also invades the chest wall and causing destruction of the ribs. And on biopsy, diffuse large B-cell lymphoma. We can see the rapid change of the lesion. This is a 2 weeks interval. On the right, we can see the first examination when we see where we see a mass, and this is on the right side. We see after 2 weeks a rapid enlargement of the mass, diffuse large B-cell lymphoma, aggressive lymphoma. Another appearance can be bronchial involvement. This is a patient where we see bronchial involvement in the left bronchus, and also we see a perihilar march which is continuous with a hilar lymph node enlargement. There is a right middle lobe atelectasis due to a mass in the middle lobe bronchus. 3 weeks later, we see this patient developing also a mass in the right upper lobe bronchus, causing obstruction with air trapping in the right upper lobe. We see this lesion and the air trapping in the right upper lobe, and also now there is complete obstruction of the left upper lobe bronchus with development of complete left upper lobe atelectasis. And 1 week later, the patient developed complete atelectasis of the right upper lobe. We can see the lesion in the right upper lobe and the mass obstructing the right upper lobe bronchus with the atelectasis in the right upper lobe. Also on the left side, we see the left upper lobe atelectasis with the central mass with the golden S sign. Patients with lymphoma, the lymphatic tumor cells can spread along the lymphatic roots, and then we have a lymphangitic spread mimicking lymphangitic spread of carcinomatosis. These patients with aggressive lymphoma with lung nodules, and also we can see here lymphangitic spread. We see this patient also with enlarged lymph node in the mediastinum. This is enlargement of one of the images that we can see here. The central pulmonary lobule with a secondary pulmonary lobule with a thickening of the interlobular septa, compatible with lymphangitic spread. Another example of a lymphangitic spread in this patient with null cell lymphoma. We see here the mass in the right upper lobe. This patient also found to have pulmonary embolism, and we see the lymphangitic spread in the lungs. We see irregular perivascular thickening and the central pulmonary lobule with septal thickening compatible with lymphangitic spread. The patient, also in this case, we see rapid progression of the disease in the lungs, and this is a two-week interval between the two images. We see the rapid enlargement of the mass here in the right upper lobe. Biopsy from this region revealed lymphoma. The prognosis of patients with secondary pulmonary lymphoma is determined by the stage of the disease and histologic subtype. Patients with, who are immunocompromised can have primary and secondary pulmonary lymphoma. This is a non-Hodgkin's lymphoma. And in patients with AIDS, there is AIDS-related lymphoma. There are several subtypes. Also in patients post-transplantation, we have the PTLD, post-transplantation lymphoproliferative disorders that can be polyclonal and benign. It is also a spectrum through a malignant neoplastic. And this is a patient after a single lung transplantation. The transplanted lung is on the left. On the right, there is a fibrosis. And we see here a mass in the native lung, in the right lung, which was found to be polyclonal proliferation. And also in the transplanted lung, we see a nodule. The treatment for patients after transplantation is if because of they receive immunosuppressant drugs, so and this is the pathogenesis for development of the PTLD, if we can stop or decrease the drug, so we can even see disappearance of these lesions. But sometimes we cannot stop the drugs, for example, after lung transplantation, and we need to give chemotherapy. Patients with Hodgkin disease, usually there is mediastinal and hilar lymph node enlargement, and it can be direct extension or isolated lung nodules. For example, this is direct extension from hilar lymph node enlargement in the lungs. We see bilateral pulmonary consolidations with high FDG activity. The role of CT-guided biopsies for patients with lymphoma. It is common to diagnose lymphoma in other sites of the body by taking core needle biopsy of enlarged lymph nodes or even organs with lesions. But in the lungs, we need, for the diagnosis of lymphoma, we need to give first for the diagnosis and also classification for treatment. We need a suitable amount of material for making the diagnosis. And nowadays, because of the improvement of the needle system and also improvement in pathology, where we can have also genetic and immunohistochemical phenotyping, we can have small samples and receive and give the diagnosis of lymphoma and also correct classification and for enough for a treatment decision. There was a retrospective study with a success rate of diagnosis of 84%, 21 out of 25 patients after CT-guided biopsy of pulmonary lesions in patients that was not suspicious to have lymphoma but underwent for masses or lesions in the lung biopsy. So the success rate was 84 for the diagnosis of lymphoma, which also gave a correct subtyping necessary for treatment. In our institution, there were 15 patients along 3 years with a CT-guided biopsy for the diagnosis of lymphoma, 6 with low-grade lymphoma, 9 with high-grade lymphoma. In all patients, the diagnosis was satisfactory for diagnosis and classification. And this is example of biopsy taking from the lesions that we saw before. In conclusion, we saw that the radiological findings in patients with lymphoproliferative disorders are non-specific, and we should remember that patients with lymphoma in the past or even with active disease, when we see pulmonary lesions, it can be secondary to involvement of lymphoma in the lungs. The FDG uptake in the lung depends on the aggressiveness and the size of the nodules, of the lesions, and the core needle biopsy can be diagnostic. Thank you very much.